Okay, it is 3 p.m. and we are going to get started. I know there's more people that are going to roll in, but today is a really good coffee and cases, and we want to just use every possible minute that we have. So welcome everyone. Most of you guys know us. I'm Ruth. I'm clinical nurse specialist for stroke here in Saskatoon, but dabble a little bit throughout the province. And this is
I'm Brett. I'm one of the stroke docs here in Saskatoon.
also dabbles a little bit throughout the province. And then our producer Ashley is also a stroke prevention nurse here in Saskatoon. So thank you for coming. As always, I'm going to start with just a land acknowledgement that's important. While we meet today on a virtual platform, I would like to acknowledge the Indigenous peoples of all the lands that we are on today and take a moment to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and affirm our relationship with each other. And just as a reminder, the purpose of our coffee and cases is to discuss pertinent topics through the continuum of stroke care, from prevention to acute to recovery to palliative and everything in between. We're sharing lots of stories and cases, but nothing specific to any patients. And just remember that we are all learning from each other. So if you have a thought or a question or something pops into your head that you think you want to ask or comment on, please do. We are monitoring the chat as we go, but of course there will also be time for questions.
It's a safe place.
Safe place.
Ask your question.
We're so nice. You know, the worst thing we're going to say is, that's dumb. But we would never.
Ruth may. Not me.
Sometimes I get a little edgy, but most of the time. Okay, you guys, I know one of the favorite parts of coffee and cases is just a second is I've made some new slides, so stand by. It's
coming. Can you guys see the slides?
Not yet. I haven't shared yet.
Oh.
Just wait. Share screen 2.
You guys see that? Give a thumbs up.
Yep.
Thumbs up. Okay. Great. You guys hear this?
Okay, so the Coffee and Cases Awards. And this is for March and also Q3. First, we are going to start with, in a second here, our TNK champions with a median TNK time of 49 minutes.
Who's it going to be?
Drum roll, and final countdown. Prince Albert! Way to go, PA. Look at this. 49-minute door-to-needle time. This is ridiculously awesome. So way to go, PA. You guys are killing it. Next award will be our Golden Lobe Award. We had one nomination. So if you think someone from your area needs to be nominated, please send it. But the Golden Lobe Award goes to the Josie House Interprofessional Practice Team. Okay, this is awesome, you guys. Look at this. Now, I'm just going to stop sharing my screen so that I can tell you what the comment was about Josie House. Stand by. Here we go. Josie House, you get the Golden Lobe Award for March because you consistently show skill, teamwork, empathy, and a desire for patient care first. You guys are a small team with limited resources, but do what you can and are successful in patients being able to get home at discharge. And the person who nominated you
is anonymous,
but they are proud to be part of an awesome unit with amazing colleagues. So you guys, who wouldn't want to be nominated for the Golden Lobe? Yeah, so please share your nominations because we want to celebrate you. We want to celebrate you. Okay, so without further ado, we're going to get to the main event. Joel and Melody are here to talk to us about, I'm assuming the post-stroke visual impairment clinic because it's awesome.
Mhm.
So Joel is a Canadian certified orthoptist with over 15 years experience as a clinician and instructor. He is the program administrator and instructor with the Saskatoon Health Region's Orthoptics program, which involved clinical and didactic instruction of orthoptic students and ophthalmology residents. Joel has a special interest in assessment and management of stroke or post-stroke visual impairment and low vision. He is committed to promoting the profession of orthoptics in Canada and abroad. And as a side note, Joel is a pretty awesome Highland dance dad. So, you know,
Thank
he's
you.
a good man when he can tolerate that much bagpipe.
That's
Joel?
true.
You rock. Okay.
Thanks, Ruth.
And we also have Dr. Melody Wong here. So Dr. Melody Wong is a neuro-ophthalmologist, an assistant professor at the University of Saskatchewan here. She trained here for med school and residency, went to BC for a fellowship in neuro-ophthalmology, but the siren song of Saskatchewan is too strong. We got her back here. So she's a neuro-ophthalmologist. She teaches residents. And I just got to say, both Joel and Melody, Dr. Wong, are assets to our province. They do amazing things with the the post-stroke visual impairment clinic too. But also, if something's going on with the eyes and I have no idea what's going on, which is most of the time, I send a referral to Dr. Wong, and you get the most detailed, thoughtful, practical letters ever. They're amazing. So I hope you guys stay here till the ends of your career, because like I said, you're assets to the province.
Okay, take it away, you guys.
Okay, thank you, you guys. Just going to share my screen here.
Sort it out. Thank you.
Okay, can everybody see that okay?
Yep, looks good.
Okay, well, thank you for inviting us. I'm going to quickly go through this talk. Hopefully it won't be more than 30 minutes or so to give Dr. Wong some time as well, and to give everyone some time to ask some questions. But yeah, my name's Joel, and here we go. So today, I'm just going to quickly go through post-stroke visual impairment, or PSVI, talk about some of the types, the incidents, and some of the treatment and management options. And then we'll talk about the PSVI clinic at Saskatoon City Hospital, kind of look at how you can refer to the clinic, what's involved in the PSVI exam, and then we'll talk about some potential future expansion coming our way. So I'm sure everybody knows what an ophthalmologist is. So they're a physician and surgeon, quite a bit of schooling. They can do it all with the eyes. So Melody here has done her medical training in her 5-year ophthalmology residency, and then did some neuro-ophthalmology specialization, as was mentioned. Not a lot of people know what an orthoptist is. So we're an allied health professional. We work within the realm of ophthalmology in North America, and we work with the ophthalmologist to help assess disorders of ocular motility, strabismus, and amblyopia. So we, after a university degree, we do a 2-year postgraduate training program in orthoptics. So we primarily work with pediatric and neuro-ophthalmologists. And then the other O's are the optometrist and the optician. So in Canada, you probably haven't heard of us because there aren't many orthoptists. We have about 200 practicing in all of Canada. And we have 1 training program now. We used to have 3, but we have 1. And so pretty low numbers. Whereas in places like the United Kingdom, they have quite a few more orthoptists, quite a few more graduates coming out. And because of this, they've been able to expand their scope of practice into many areas, but 2 of which are low vision and stroke. So the reason I'm talking to you today is because I have a little bit of history in low vision. So 20 years ago, wow, I spent 2 years as a low vision rehab specialist. And since about 2015, I've been trying to reestablish a low vision clinic at City Hospital here. Early on, I was encouraged to look into some additional training in low vision. And that led me to do my master's through the University of Sheffield in England, where I was able to be accredited in low vision assessment and then kind of stumbled into stroke assessment. So low vision is an umbrella term. It's meant to kind of capture any type of visual impairment. And so I've just broken it down here into 3 different areas just to kind of simplify. So the low vision term itself is quite broad. You can have neurological low vision, acquired low vision, and congenital low vision. So today we'll be focusing on the stroke, or what we call the PSVI portion. Just a few terms. Low vision is any visual impairment that cannot be corrected to normal levels, either medically or optically, and that starts to impede on people's activities of daily living. Vision rehabilitation is a proven healthcare service that optimizes a person's remaining vision and teaches them skills to help maintain and regain independence. So think of the PSVI clinic as vision rehabilitation for a small subset of patients with low vision. Okay, we'll get into PSVI. So I don't have to tell anybody here that stroke can cause many signs and symptoms. But when you think about how much of the brain is comprised of the visual pathway and the vision itself, it's kind of strange that when you look back in the literature, you wonder why vision wasn't really focused on, pun intended. Why is it important to identify visual impairment? Well, there's really good evidence that visual impairment really impacts everyday tasks. So there's a greater risk of falls and injuries. It doesn't take much visual impairment to develop reading difficulties, and visual impairment causes a loss of independence, social isolation, and depression. And rehabilitation may be delayed or less effective if visual deficits are not identified and addressed. So if you look back in the literature, prior to 2009, there's really almost nothing concerning visual impairment and stroke. And then around 2009, a group of orthoptists and ophthalmologists and optometrists out of the UK, kind of led by Fiona Rowe out of the University of Liverpool, developed a group called the Vision and Stroke Cohort. And they wanted to do some research and kind of look into visual impairment due to stroke. So some of the big questions they had were what types of visual impairment occur from stroke, how common is post-stroke visual impairment, and what treatments are available for these patients, and are these treatments validated? So we'll look at those questions. So from their research, they divide PSVI into 4 main areas: visual field deficits, ocular motility disorders, central vision impairment, and visual perceptual disorders. So we'll just quickly go through each of those. So visual field deficit's pretty well known in stroke, and it's not surprising that if you have an MCA or PCA stroke, you're likely to have a visual field deficit, and you can predict what type of impairment you'll have based on where the stroke occurred. Ocular motility disorders, these are due to brainstem or cerebellar involvement, and they include your cranial nerve palsies, horizontal and vertical gaze palsies, acquired nystagmus or shaking of the eyes, issues with your slow and fast eye movements, and issues with your convergence. Unless the stroke affects the anterior visual pathway, it's not likely to create many central vision impairments, but quite often these patients have pre-existing ocular conditions. They may have some focusing issues, and they may have an uncorrected refractive error that can be complicating their rehab. And then the visual perceptual disorders are those higher order or cortical dysfunctions, including visual inattention and neglect, the various visual agnosias, and visual hallucinations or Charles Bonnet syndrome. So they also wanted to see how common PSV might be in the stroke population. So the impact of visual impairment after stroke, or IVIS study, I won't go into all the details, but they did a lot of work looking at the incidence and prevalence, and they concluded from this study and several others that it's estimated about 60 to 70% of all strokes will have some form of post-stroke visual impairment. From their research, they also determined that vision screening and a full vision assessment for most stroke patients is possible within 5 days of stroke. Another important thing they found is in their research is that about half of stroke patients who have a post-stroke visual impairment are not aware they have the visual impairment. And that doesn't just apply to those with visual neglect. You can see here from this large IVIS study, in all 4 areas of visual impairment, about 50% of patients denied having any symptoms and were then found to have actual visual impairments on assessment. So then when we talk about treatments, fortunately, in many cases, many of these visual impairments do resolve or at least improve with time. The research shows that if they're going to improve, most will do so within the first 3 to 6 months after stroke. There have been a number of systematic reviews looking into the various interventions for PSVI. Currently, there is a lack of good evidence for many of the interventions, but I'll just talk through some of them right now. So when we're managing PSVI, there's 3 approaches: either compensatory, where you teach the patient to adapt to the impairment; substitutive, where you use devices to alter or enhance their vision; and restorative, which is therapy aimed at restoring lost function. So looking at visual field deficits, compensatory approaches usually consist of eye scanning therapies or visual search strategies, and these are currently considered the best form of treatment. Typoscopes is just a fancy word for this image here, this piece of black plastic that can be used to simplify your reading environment and define the borders. So for somebody with a hemianopia, these could be really helpful to help patients know when they've reached the end of the column of text, and it can just kind of help simplify their reading practices. Vertical reading is another option. So if you had a right-sided hemianopia, it's going to be hard to read. You're going to miss some of the words on the right side of whatever you're reading. So people found that sometimes if you turn whatever you're reading vertically, it doesn't work for everybody, but some people really like this. So that's another option. Simple little changes can make a big difference for some people. Other things that are sometimes used are teaching patients how to use compensatory head postures, and then sometimes referring people to for orientation and mobility assessment to help them travel around their environment more safely. Eye scanning therapy, there's quite a few out there, and they range from everything from free, such as the eye search therapy out of the UK, to other programs which cost hundreds of dollars. But there's quite a few out there. And again, they're just teaching people to scan into their affected area, blind area. I'm often asked about prisms for people with hemianopia. The theory behind prisms makes sense. The practicality of it doesn't seem to work out quite as well as we hope. But the idea is, if you look at this picture down below, this patient has a left homonymous hemianopia. So everything to the left of fixation is gone. By placing high-power prisms above and below the line of sight, they allow a little bit of a peek into that blind hemifield there. So you can understand how this could be useful, and some people do find it useful. I've found through trying in about 24 patients that it makes sense until you apply it and try it in a busy place, and then it can become overwhelming. But it is another option for some. For restorative therapy for visual field deficit, Nova Vision is a company that offers vision restoration therapy. This program consists of 2 sessions, 25 minutes a day, 6 days a week for 6 months. And they claim that they can permanently restore up to 5 degrees of lost visual field. The reviews on this are, well, it's controversial to say the least. 5 degrees doesn't sound like a lot, but when it affects your central vision, that can be huge. Controversial to say the least. Very expensive, very time consuming, but interesting. For ocular motility disorders, these are often subtle, more difficult to detect, and they're difficult for patients to describe. They cause significant difficulty with activities of daily living, and ocular motility disorders are shown to have a negative impact on successful early rehab, and they can result in prolonged inpatient stay and delayed recovery. This is really where orthoptists come into play. This is our specialty here. So sometimes it's simple compensatory methods, such as giving patients coping strategies, teaching head postures, maybe occluding one eye or part of the vision in one eye. A lot of it is just explaining to patients and families about the functional implications of their various ocular motility issues. Substitutive treatments include prisms and magnification, and restorative treatment consists of strabismus surgery and orthoptic exercises. For those with central vision impairment, sometimes it's as simple as correcting or updating their glasses. Again, providing information to explain the functional implications of any pre-existing ocular conditions, treating any kind of focusing issues, and referring for low vision if necessary. For visual perceptual disorders, this is really not my area, but the research shows that often a combination of both compensatory and restorative therapies is likely best, but feel free to tell me if I'm wrong about that. So to sum up the research, starting in 2009 and continuing today, post-stroke visual impairment is now generally accepted to occur in about 60% of strokes. Half of those patients are not aware of their PSVI, so just asking them if they have a visual impairment is not enough. There are a wide range of visual disorders that can occur due to stroke, and there are treatment options available. So due to this research, the group in the UK recommended that all stroke survivors require screening for PSVI and should be referred for specialized assessment and targeted treatment. So I mentioned Professor Fiona Rowe. She's kind of led the charge in PSVI. She's an orthoptist that she heads up the vision research group at the University of Liverpool, and her and her group have really done most of the research into PSVI. So her group developed the VISA tool, or Vision Impairment Screening Assessment Tool, which is the first validated screening tool specifically designed for PSVI or acquired brain injury. It's free to use, it requires minimal tools, it has printable instructions and testing sheets, and instructions on how to interpret findings and when to refer to an eye care professional. It consists of 5 parts. There's a history section, and then a visual acuity, which consists of some letters for patients to identify. There's a matching card if they're not able to speak, and there's another option if they can't match letters. There's a basic instruction on how to assess eye alignment and ocular motility, instructions on how to do a confrontational visual field assessment, and then screening tests for visual attention. So in the UK, thanks to their work and the big number of orthoptists over there, they really pushed to become part of the stroke multidisciplinary team. And it's now considered in the guidelines that each stroke unit ideally should have an orthoptist as part of their core multidisciplinary team. So coming from that background and learning through the UK system, I thought, well, maybe we can do this in Canada. I know we have a smaller number here, but can we can we adapt the UK model to develop PSVI clinics in Canada? And we can, because we did it here. So if you look at the stroke best practice recommendations, they don't mention much about vision. They do recommend that people should be screened for visual motor, and visual perceptual deficits. And they do provide guidelines for visual neglect or inattention, but there are no recommendations currently for any assessment and treatment of visual impairments caused by the stroke. So back in 2020, with the help of Ruth and Dr. Graham and Dr. Shi, we ran a PSV pilot study. So over that time, patients were referred to me for a PSVI assessment, and we did some questionnaires before and after, just to kind of gauge what patients thought of the service. So over the period of October 2020 to May 2021, we had 18 patients that completed all the questionnaires, and overall it was very positive. So they felt they got care in a timely manner. They felt they had a better understanding of their visual impairment from stroke, and we concluded that the assessment did significantly improve quality of life in a number of constructs there. And then we published a paper just kind of explaining how we took the UK model and adapted it to Canada, and kind of went from there. So thank you to Ruth and Dr. Graham for all your help with that. Okay, now we'll talk about the clinic currently. So right now the PSVI clinic is run on Mondays and Fridays. Purpose is to provide vision assessment, management options, and information for stroke patients with visual impairment. Patients that are referred must have a confirmed stroke, and they can be referred from ophthalmology, neurology, or rehab services. And the way to refer is to use the PSVI referral form. So this form just has some basic patient demographics, and then lets you kind of click or check off their stroke deficits, and then any perceived or any visual impairments that the referee thinks the patient may have. Lets you put in your priority for when you'd like the patient to be seen. Once a patient is booked in for an assessment, they're sent out a PSVI questionnaire. And this just lets ask the patient if they had any visual issues before or after the stroke, and also lets family members or caregivers an option to put in their comments to it. Then when they come for the assessment, there's a brief history done, review of that questionnaire. If they have a stroke that is thought to have that is likely to have caused a visual field deficit, we'll do automated visual fields. If not, we will do an automated field if there's time, but sometimes it's just limited to a confrontation field. Test visual acuity. We'll check and see if they need glasses or if their current glasses are still correct. Tests of contrast sensitivity is done, as this is a better predictor of functional vision than visual acuity alone. And then they'll have a binocular vision and ocular motility assessment similar to an orthoptic assessment. And we'll do some screening tests and talk about visual perceptual issues that may have. Patients then get a summary report of their exam, and then another report is sent to the referring parties with recommendations and follow-up if planned. So the report is intended to provide a summary of the assessment, of course, but to identify visual impairments, describe some functional implications of those impairments, also to identify normal visual functions, and to talk about possible treatments or management options, and discuss a follow-up plan if needed. So in my training in the UK, they're very big on providing patient information, and I really like that. So everybody I see is sent home with just a little patient summary sheet, just kind of looking over the areas that were potentially affected from their stroke, and just a little notes about, was it normal, was it abnormal, a little bit about the treatment plan, and then follow-up dates. We also have information sheets for for patients and family members on various topics relating to PSVI, and we hand those out as well. Just want to be clear, sometimes patients come expecting to get their license back that day. That is not part of the PSVI assessment. And I don't think they're being told that, but they sometimes come back expecting they'll walk out of there driving, but it's not the case. Every patient that I see is then referred to an ophthalmologist. So if they're already following with an ophthalmologist, I usually just send it to that ophthalmologist. But since Dr. Melody Wong has started up here, she has very graciously agreed to see the vast majority of those patients. So thank you to Dr. Wong for taking that on, and thank you to Dr. Murphy, who was seeing the majority of those patients before Dr. Wong started. So these are my perceived strengths and weaknesses of the current PSVI clinic. I think in theory, it's helping some stroke patients with visual impairment because they're getting vision assessments. Hopefully the rehab teams are getting useful information about their visual function, and hopefully that can be used to help with their rehab. I think it strengthens some interdisciplinary communication and collaboration, and it allows me to use my training to actually try and help people. So those are my strengths. Some weaknesses I see are the limited spots, currently limited to Mondays and Fridays. It's not a widely advertised service. It's only in Saskatoon, and I feel that the stroke patients are not getting the assessment as early as they should, and that's usually just because limited spots are available. So since kind of officially starting in 2021 on this part-time basis, there have been over 550 patients referred, 300 by rehab services, 215 by neurology, and over 50 by ophthalmology. We can't have coffee in cases without some cases. So this is case one, a left MCA stroke. It's a 70-year-old male, had a left MCA stroke 2 weeks ago with expressive aphasias, suspected right-sided visual field loss, and possible right-sided visual neglect. So when he comes in for the assessment, we can do an automated visual field test, and we can confirm that yes, he's got a complete right homonymous hemianopia. He wasn't able to identify letters, and he wasn't able to match letters, but we have some other vision testing equipment here. So we were able to assess his visual acuity and found that he was 20/20 for either eye. We checked his prescription, and his current glasses are optimal. Ocular motility and binocular vision assessment was normal, and did some screening tests for visual neglect, which were performed normally. So based on the assessment, our recommendations are that we repeat the visual field test in 3 months, as these visual field deficits may improve or resolve with time. He asked about whether or not he should keep his glasses, and we recommended he continue with the same glasses. And based on what we got with the screening tests, we assume that he doesn't have any significant visual neglect. And so then hopefully rehab can focus more on therapies for the right hemianopia without having to deal with neglect. For the patient and for the families, we gave information sheets about vision field loss, how it may improve, some tips and tricks for how to adapt to the visual field loss. We were able to tell the family and the patient that it looked like his visual impairment was limited to visual field loss only at this time. And then we introduced him to therapies for visual field loss, such as eye scanning therapies, orientation and mobility training, and vertical reading. In the interest of time, I'm going to skip over the next few cases. I'll talk about the future plans for the clinic. So as of 2026, there is potential to provide PSVI assessments full-time, hopefully starting around summer. Dr. Wong and I are currently working through the process of trying to establish a full-time vision rehab clinic, which would assess PSVI, but would also assess all those other forms of low vision. So we'll see. So again, I think maybe the first step might be more of the neurological low vision options, but over time we'd love to expand to those acquired low vision cases, and then even get into the congenital low vision cases. This is just showing there's a set pattern for vision rehabilitation. There are certain steps that have been recognized to be necessary and useful. So just showing here that the current setup for the PSVI clinic follows that pathway, and as would the our proposed method for low vision that Dr. Wong and I are working on. So recently, there was news that City Hospital will soon house the province's first dedicated unit for acquired brain injury. Just like stroke, acquired brain injuries very commonly has some type of visual impairment involved. And so it makes sense to me that if there is an ABI center here, of course they should have access to the PSVI clinic. Again, that visa screening tool was developed for PSVI, ABI. Maybe it would consist of an ABI assessment either with myself or with other orthoptists here, and there are treatments and recommendations for those patients. And then very last thing here, so Dr. Rowe and that whole UK team, word is starting to spread about the value of PSVI assessment. So in Europe, they're adapting the models. In Australia, they're adapting the models. And then in Canada as well. So back in 2024, Canadian Stroke Congress was in Calgary, and they invited Dr. Rowe over to talk about PSVI. And then Alberta actually developed a PSVI pathway, which I'll just show you here. So involves a screening assessment, and then it just shows you where to refer to, whether it's ophthalmology, optometry, orthoptics, occupational therapy. So they've used all that information that was developed by the UK group, and they have now established this PSVI pathway in Alberta. Okay, I'll stop talking. That's my number, fax machine number, email. Either email is fine to use if you have any questions. And stop sharing. Thanks for listening.
Okay, thank you, Joel. There is one question, but I wonder, Melody, if you want to chat first, or are you answering questions, or what are your...
I don't have super much to add to that. Yeah, happy to answer any questions. And I guess I would say it's quite satisfying and really nice with those patients that have the visual defects for whatever reason, if we can catch them early and we can explain things to them and kind of just walk them through the process, sometimes even seeing them and being able to identify what they have and give a little bit of prognostication as well. I find patients really enjoy that, and sometimes just a little bit of vision hand-holding, I suppose, throughout the journey can be helpful as well after stroke. So I saw the question in terms of for people who have had strokes years ago. I'd say that there can be a role that we can still play too. It might not be as useful for obviously the rehabilitation and such like that, but there are a lot of patients that we see that didn't have this process and sometimes don't understand their visual field deficits, or sometimes there are things that we can help them with, like the reading strategies and whatnot. So I'd say we still not as big of a role, but still have a role in some of the patients that have had strokes a while ago.
And you guys mentioned, like, or Joel, you mentioned that like you don't see stroke patients early enough necessarily. So I know in best practices, rehab, being not a place but a journey, should start at about 48 hours post-stroke, 24 to 48 hours. Is that when visual rehab should ideally start? I mean, that's really hard, but just wondering what would be the best practice around it.
Yeah, so in the UK, they do try and get in there within 72 hours, but those are orthoptists on the stroke wards essentially, or coming in to look around, to do it at that point. So you know, even 5 days after is good from my point of view. The ones that I they're just disappointing is when rehab will refer to me and I just can't get them in before they're discharged. And then, you know, it's really a shame that they were here, sometimes right here at City Hospital, didn't get a chance to see them. Now they've gone home 3 hours away. They got to come back. It's like, of course they should be seen when they're here, right? So I think some of that will improve if I'm able to do this full time. And maybe it involves changing. Maybe it involves, you know, we've talked in the past about maybe me going up to rehab and doing screenings and testing there. There's lots of options.
So that kind of answers the question, is Joel part of the inpatient rehab team in Saskatoon? But you're not. You run this clinic is totally separate.
Right. Yeah.
And can you tell us a little bit, Dr. Wong, about the prognosis of visual impairment post-stroke?
I'd say in general, I tell patients like it takes a long time for brains to heal, and we often give them even up to a year for healing, and kind of depends on what we're looking at in terms of visual field defects. I'd say the vast majority of people with a visual field defect don't get full recovery of their visual field defect. Usually, well, within the first few months, if we have some recovery, the chance of further recovery is better. But if there's not a lot of recovery within the first few weeks to months, chances of further recovery are fairly slim. Although I will say I have had a couple surprise patients who had quite a bit of recovery even a few months down the road. So just kind of getting them used to that and kind of understanding what that is sometimes helpful for patients just to appreciate. I always do tell people though too, even if you do have a hemianopic defect, your brain will consciously or subconsciously learn that you have that field defect. You're not going to stare straight ahead all of the time. You're going to move your eyes, you move your head, and once you learn why you have that field defect, we can teach you screening strategies and scanning strategies to help overcome or utilize the vision that you have remaining. And surprisingly, no matter how many times people go through this process, there are so many patients with a hemianopic defect that think it's just in their one eyeball, and they just keep thinking, if I get glasses or whatever, I can fix this one eyeball and everything will be better. So getting that settled earlier sometimes is helpful too. Ocular motor deficits are a little bit more unpredictable, I'd say. It kind of depends on how exactly they're affected, the degree of how much it's affected. And so some of those are a little bit harder to track, but it is nicer because we do have more things we can do for that with prisms. And sometimes I'd say the patients with the ocular motor deficits that we can help with prism, those are probably the most satisfying, because a good prism eliminating double vision is huge for patients.
And Brad,
What? I was waiting.
he's listening, I promise.
No, if you have a question, I have a comment. If you have a question, please.
Well, my other question is, so like what's the follow-up look like? Like, is it one and done, or what ideally do you practice with the patients? And then I know you had a whole list of things kind of that our occupational therapists can kind of, that's more of like the neglect side mainly, but I'm guessing OTs are probably could function a little bit more like a surrogate of you two when you're not always available. So I don't know if the OTs have any questions about practical ways to address, but yeah, first off, what is the ideal for you guys in terms of follow-up?
So I guess, so first of all, Dr. Wong does not work out of the eye center. So right now they'll usually see me first. I'll do my assessment, and then I'll send them over to her, depending on when she can see them. If I find in my assessment that everything is normal, then I don't plan to see them back. If they've got a visual field deficit, I usually follow a 3-6 month time frame, just from the literature, just kind of showing like, probably if you have a visual field issue, it's within the first 6 months. Again, but like Dr. Wong said, sometimes it's longer. And then for ocular motor issues, we give up to a year. So patient comes in with diplopia. We figure out, yes, this is a cranial nerve issue. We'll give them a prism, and then I'll kind of follow them every month or every 2 months, just a quick check, just to double check and make sure that things are either resolving, or if there's stability, then once we've had stability for a long enough time, then we can refer to an eye muscle surgeon.
And are there virtual options, or you really need to see them in person?
We haven't done anything virtually yet, so it's all been in person.
Ocular motor deficits would be probably impossible to do virtually.
Yeah.
Visual fields,
Yeah.
maybe, yeah.
So just to clarify, someone asked, does this mean that only Saskatoon residents are seen? So this is a provincial program, correct? I know you only have 2 days, but this is the dream.
Yeah, I think the biggest issue is there's one of me and there's one Dr. Wong. So while initially I was like, yeah, send everything. We can't see everything, right? So and then if people are coming from 4 or 5 hours away, there are times when Dr. Wong and I can kind of coordinate. So maybe my first follow-up appointment with them, I'll see them in the morning, and then they'll go across to her office in the afternoon, and that works. I think that works pretty nicely. So if there was more demand from out of the Saskatoon area, we'd have to maybe look at coordinating those more. But it's definitely open to anyone who may need the service. I think if I could say one thing, it's tricky, right? Because I just said that half of these people will say they have no visual impairments, but they actually do have a visual impairment, right? So sometimes we see some that they're totally fine. Sometimes we get referrals where it's like, well, they say their vision's a little blurry. It's pretty vague. And then, they come in and it's like, well, yeah, my vision's blurry, but if I put on my glasses, it's great. And so it's like, oh, that person probably didn't need to be seen. But how do you know which ones to allow? And so I don't have a good answer for that. I would say sometimes we get some where the only visual issue that they are feeling it might be is a visual neglect. Those ones are good to see to rule out any kind of actual visual field deficit, which can co-occur. But as for what I do with visual neglect, it's very basic and it's pretty much screening. So the OTs will do much more than I'd ever do for that type of case.
And as you kind of mentioned with occupational therapy, back for that post-stroke visual impairment clinic pilot in 2020, 2021, like 5 years ago almost, crazy. We partnered with occupational therapy here at RUH, and they did the visa assessment in regards to that to kind of catch the patients who had post-stroke visual impairment. So if you don't have a Joel or Dr. Wong where you are, the occupational therapist can probably be a big help to screen those people. And like I said, there's the visa tool is free online, right? So for occupational therapists, they can download it and kind of go through it and kind of do just structured screening things. So it's kind of great. It goes hand in hand with that referral form. I kind of said at the beginning that we have 2 Saskatchewan assets. Chatting to us, it's true. I only hear good things when someone sees Joel at the post-stroke visual impairment clinic, right? The education that's provided, the kind of tips and tricks, people feel better, they have kind of more control of what's happening, and their quality of life increases as well too. So it's a great asset. And even Dr. Wong too had a patient, I think we both follow, but I saw yesterday, and he was like, yeah, I saw Dr. Wong last week, and he said, she's excellent. I'm like, I know. So having them here, kind of both here, they're not over their training and their experience, but their passion for what they do is amazing to see, and it improves patients' lives.
Well, and if I know anything, if Alberta did something, we can certainly do it better.
Because this was the first post-stroke visual impairment clinic in Canada.
In Canada.
And now
I think in North America. Yeah.
North America.
We'll see.
Yeah.
And your oil money. Jeez, do we have access to PSVI information pamphlets? Hey, stay tuned in the Ashley.
I'll do something in the newsletter.
In the newsletter, there will be the referral form. There will be information. We will put
Visa screening
a
tool.
link to the visa screening tool so that you guys can
Yeah.
access and have it. And
Joel's fax number. If you ever have a question, send him a fax.
fax. We can
Yeah.
put a man on the moon, but we still have to use faxes. I don't know. I'm not sure how this works. Thank you
Yeah,
guys so much.
Any other questions? Here. Remember, this is a safe
Yeah,
place.
safe place.
Safe place. Raise your hand, talk, type.
Okay, well, at least turn on your cameras and show them that you listened and loved their presentations. There. Yeah, here they come. Look at
Somebody's in a vehicle. So we got some people, somebody raised their hand, but then they lowered their hand. Okay,
Maybe
maybe
we waved.
there's a wave.
Oh, this is so great. Thank you guys for showing us your listening. Yeah. What a nice community we have. I
So-
just love it.
Are you guys ready for the big increase in referrals you're gonna get now?
I guess so. Yeah.
550 in 2 weeks.
Keep it, they'll come.
Easy for me to say if I'm just doing these, and poor Dr. Wong is
the summer
he's the only
2026,
neuro-ophthalmologist in the province,
right? Full-time clinic, you said, right?
Full-time clinic.
24/7,
Potentially.
7 days a week.
Okay, Ashley, you have something to share with us.
Yeah. Can everyone hear me if I just use Ruth's mic?
Yep.
Mhm.
Yeah,
that's-
okay.
that's up.
Perfect. Okay, so we have stroke day, or stroke month is in June. This is not sharing. Is it showing?
Not yet. Oh, there we go.
Okay, so stroke month is June, and the last couple of years here in Saskatoon at the Stroke Prevention Clinic, we've had a stroke day. So we set up a booth at RUH mall, main mall area. We have some music and some balloons, and we're all wearing our heart and stroke t-shirts. And we basically stop passerbys and kind of do a little bit of education on stroke. We have like a little sheet. Let me see. Can you see that one? Yeah. Website.
We take blood pressures. We hand out swag.
Blood sugars. We kind of do a little bit of a screen and some education,
Why isn't this sharing?
and it's coming.
I'm just not tech savvy, you know. Anyway, so we do a little, we take blood pressure, do their heart rate, we use the cardio mobile, we do the blood sugar level, and then we kind of go over their stroke risk factors and talk a little bit about that. And then at the end, we usually have some heart and stroke swag that they can take home. Like a workout towel or a lanyard.
This is it from one. Right?
Yeah,
Yeah.
there's some pens and keychains.
And so, you can't see that. Just read my note here from Meredith. Okay. So she said, and I'll put this in my newsletter as well here. So they're arranging to have some toolkits made. So each one person, I think, per town, right, per center.
Yeah, per center.
Can mail in to Effie from Heart and Stroke, and we'll send a package to you full of SHA and Heart and Stroke resources. And then the prize, the size, like the swag size, will depend on how big your center is. We'll have our package out by the first week of June, and a contingency to receive your packages, you have to send us photos of your booth.
But it would be so great if we could all on June 17th have a provincial stroke day. I know Regina's in already. Saskatoon's in. I think the rehab units are in. So, but our province, as we see here, is way bigger than Regina and Saskatoon. So we have the packets, we have the swag. We just need you to reach out and to Effie at Heart and Stroke.
Yes, I'll put her email address in the newsletter, and then just the information that she needs. And then there'll also be a link to order a Heart and Stroke shirt if you want. That's not
part of the
That's not
swag.
part of-
Sorry.
it's not for free.
But I mean, they're so fashionable. You can wear it anywhere.
Yeah.
Dress it up, dress it down.
Very nice.
Put a blazer over top of it.
Blazer.
Yeah.
Listen to this guy.
Yeah.
Your pumps, mini
Sure.
skirt,
Yeah.
clubbing. No, I'm too old for that. But so yes, that is what's going down. So please, watch the newsletter. Please, please, please submit for the Golden Lobe, you guys.
Yeah.
Yeah.
It's so fun and cute. And your center deserves to be recognized. So way to go, Josie House. Way to go, PA, our TNK provincial champions.
Keep it up.
Keep it up. And Christy popped in a message. I don't know if Joel and Dr. Wong saw. Thank you. It's so good to know more. My father was seen by both of you after his stroke, and think you were both fantastic. Great patient encouragers. So I will just unofficially give you guys the Golden Lobe.
There we go.
You guys rock.
This is another question. Are you guys planning on hiring any OTs?
No, that's an RUHOT. No, they're not. You are staying right here. Who is that?
I'll find out.
Find out who that is.
We are trying to get a part-time MOA, and that seems to be nearly impossible. So we haven't even tried for anything like an OT, but we do use the city hospital OTs for sure.
But you could use some coordinators, and you could build a huge team.
Our next step is to try and expand into low vision in general, which was a very multidisciplinary
Yeah.
OT heavy. Yeah. So
Yeah.
we'll see.
So
Only
next week,
been-
next month.
Oh, next month, you guys. These are great months. Next month is going to be Women in Stroke, and we have a special guest speaker, Allison Plecash, and she is a stroke neurologist in BC who has a special interest looking at women and stroke and the causes of stroke throughout our female lifespans. So this is going to be a really cool month. You don't want to miss it. But if you do, these sessions are recorded and they're up on our Coffee and Cases YouTube page.
Give it a like, right?
Give it a
We
like
get 1 million likes. Don't we get a plaque, I think, from YouTube?
and $1 million.
Some money. So yeah.
No, I have no idea.
I think we get a plaque.
Okay.
But we need 1 million,
Million
lots
likes.
of
I think we have
likes
6
or views or
subscribers right now.
Let's the goal is by next month we'll have 12 subscribers. Double it. That's the goal.
Yes. Okay, you guys, thank you for coming, and hope you have a fantastic weekend.
And happy Brain Health Awareness Week, apparently.
Brain Health Awareness Week. Have your omegas.
Leslie Long raised her hand. Oh, there's raised the roof, maybe. Thank you, Joel and Dr. Wong, for
Thank you
joining
so
us.
much.
Thank you.
Thank
both
you
so
very much.
Okay, see you guys next month.
Bye.